Hello, my name is Kathleen Kobashi. It's a real pleasure to be here to talk to you today about advances in the treatment of overactive bladder. One of my nurses recently came up with a clever analogy, and this map showing locations of Starbucks in Seattle could be construed as either 20 Starbucks or 20 restrooms. I'm sure a lot of our patients actually choose the latter, but it's all a matter of perspective. Now, urinary incontinence has an official definition that was coined by the International Continence Society, and that is the involuntary loss of urine that represents a hygienic or social problem to the individual. There are various types of urinary incontinence, all of which result in urinary leakage, but they all have different symptoms. And today we're going to concentrate on urge incontinence, which is specifically the type of incontinence associated with the urge to void or a sensation of gotta rush to the bathroom. Now, urinary incontinence in general is an extremely prevalent problem, affecting 10 to 20% of women ages 15 to 64. 40% of women greater than 60 years of age experience urinary incontinence, and more than half of institutionalized patients of both sexes, male and female, are affected by urinary incontinence. Specifically with regard to urge incontinence or overactive bladder, more than 33 million adults in the United States are affected. 11 million of those patients actually have urinary incontinence associated with the urgency or sensation that they have to void. 40 to 70% of elderly patients or elderly people have urge incontinence, but less than 40% of patients seek treatment. A recent look at a national survey from the National Center for Health Sciences looking at the chronic conditions that bother patients in the United States, overactive bladder was slated as the second most common chronic condition that affected patients in the United States. But if it's such a prevalent problem, why don't more people seek treatment? And who seeks treatment for urinary incontinence? Well, it really depends, and it depends on a lot of things, including patient education. There have been a lot of common misconceptions and things that I've heard from our patients, such as it's a normal part of aging, there's not a whole lot of treatments, there's nothing successful, it's not severe enough to treat, or it's too embarrassing to discuss. And I consider all of these really, truly misconceptions. Patients will manage their symptoms on their own with things such as protective garments and pads and protective padding for their beds or chairs. Now, urinary incontinence is a very expensive problem, and in 1995, in the age group over 65 alone, it was estimated that 26 billion healthcare dollars were spent on urinary incontinence. That amounts to $3,500 per person per year and represents a 74% increase over a decade earlier. Now, if we continue on that trend, we're probably getting close to about $5,000 per patient per year now in 2005. Looking at overactive bladder alone, 16.3 billion 1995 healthcare dollars were spent on overactive bladder specifically, more on women than on men. Clearly a very expensive problem. This pie chart here represents the division of all the components that go into this $16.3 billion. And what's important here is this nursing home admissions at 14%. The reason why I point this out is I recently heard about a new report showing that the most common reason for nursing home admissions now is urinary incontinence. So clearly a huge prevalent healthcare problem. Now, I like to think of urinary incontinence as either a failure to store the urine or a failure to empty the bladder, both of which can result in urinary incontinence. We're going to concentrate today on a failure to store the urine, which can be caused by a problem with the bladder or a problem with the outlet. A problem with the outlet is the common leakage with coughing or straining, which we're not going to concentrate on today. Rather, we're going to talk about a failure to store the urine because of a problem with the bladder being overactive and unable to store the urine as it's supposed to. The symptoms of overactive bladder are urgency, a feeling of I gotta go, I have to rush to the bathroom. Urge incontinence, which is urinary leakage associated with that urgency. Urinary frequency, which is a sensation that you have to go very often. And oftentimes patients will experience nighttime urination. So I think it's important for patients to know that they can ask their primary care provider or specialist about successful treatments that are currently available. But perhaps more importantly, I think it's very important for patients to know that overactive bladder can be caused by other issues as well. And so it's very important to eliminate infection or other pathology such as a stone in the bladder or a small tumor in the bladder that could also irritate the bladder and cause patients to have a sensation of urgency. So some key questions for patients to consider when they're trying to figure out whether or not they may be having overactive bladder are, do you ever get a sudden uncontrollable urge to urinate? Do you ever feel like you can't make it to the bathroom in time? How often do you urinate? And how many times do you get up in the middle of the night to go to the bathroom once you've gone to bed? If you end up in a specialist's office, we may do some other tests such as urodynamics, which is a function test of the bladder. It involves measuring the pressures in the bladder and the patient's sensation with regard to how full the bladder is, bladder emptying ability, and whether or not the bladder is having spasms, etc. Another test is cystoscopy, which is placement of a small telescope into the bladder to make sure the inside of the bladder is healthy and that there's nothing in the bladder irritating it and causing some of these symptoms. This is our urodynamics laboratory at Virginia Mason, the Continence Center at Virginia Mason. And what's illustrated here is the patient standing getting an x-ray of the bladder performed, while in the background there we're looking on a computer screen which is showing the measurements of the pressures in the bladder. A very important function test that helps us determine what the patient's bladder function is. So let's talk about treatment options for overactive bladder. There are various treatment options available, again, very successful treatment options. The first 3 to 4 of these listed here are options that are often clumped together and often used in combination with each other. But we'll go through them briefly one at a time. Behavioral modification is simply dietary control and bladder training. Possible bladder irritants that can actually contribute to the bladder feeling like it's got to go more often are caffeinated beverages, alcohol, and some other reports have suggested spicy foods, tomato-based foods, citrus juices or fruits, and then chocolate, which probably goes under the heading of caffeine. But we do counsel our patients to avoid caffeinated or alcoholic beverages or excess fluid intake. And it's important for patients to really understand what beverages they consume that may be caffeinated. For instance, Mountain Dew, a lot of patients don't realize that that has a lot of caffeine in it. And be very cognizant of what it is that they're taking in that could be contributing to their bladder irritation. Bladder training is also something that we use very regularly. And in short, what bladder training is a timed voiding pattern. So we teach the patient to void at certain intervals and gradually increase the interval between the times that they urinate. So in this way, the patient actually learns to overcome the urge to void and actually learns to control that bladder urgency. There was an article about 15 years ago that actually reported on the success of bladder training alone, suggesting that incontinence episodes were reduced by 57% and the quantity or the amount of urine loss that a patient experienced was reduced by 54% in patients who used bladder training very diligently. Now on to pelvic floor exercises. Many patients think of pelvic floor exercises as Kegel exercises, and sure, that's one type of pelvic floor exercise, but that tends to be more successful for stress incontinence or leakage with coughing and straining. For overactive bladder, we actually teach patients to do what we call quick flicks. So there are strong, quick, rapid contractions of the pelvic floor that actually can result in inhibiting unstable bladder contractions that result in a sensation of urinary urgency. And a study that looked at the success of quick flicks or pelvic floor rehabilitation on urgency showed a complete resolution of symptoms in 20% of patients. And 50 to 75% of symptoms were reduced in most of the patients in the study cohort. Now, biofeedback requires monitoring instruments that actually give the patient some feedback with regard to whether or not they're exercising and tightening and relaxing the proper muscle groups. And in this way, the patients can learn to control things that they previously thought were uncontrollable, such as urinary continence. Now, the drawbacks of biofeedback include that it's a bit costly, not only in a financial sense, but in a time sense, because the patient needs to be very diligent and very motivated and show up on a once every week or 2 weeks to have a biofeedback session. It requires a lot of dedication to the program, which needs to continue even after the formal program is completed. And it's a very specialist-oriented therapy. So I think it's very good in those patients who wish to avoid any medications or invasive procedures, but it takes a lot of work and dedication on the part of the patient. That, as well as the pelvic floor exercises and behavioral modification, are best when used in combination with the other conservative measures. So there was a study that was recently published that showed that behavioral therapy alone resulted in a 57% decrease in urinary incontinence episodes at 8 weeks after the treatment started. Drug therapy alone resulted in almost a 73% reduction in incontinence episodes, but when drug therapy was added to the behavioral therapy, or when behavioral therapy was added to the drug therapy, more than 80% reduction in incontinence episodes resulted. So clearly, in combination, all of these conservative measures are more successful than anything alone. Now, pharmacotherapy, it's a fancy word for medications, and this is what we use most commonly for overactive bladder. But there are a plethora of medications available, and more are coming out on the horizon every day. So it's quite confusing. And how does one know which medication to choose? It's a bit of a dilemma, I must say. But the ideal agent is one that would be a long-acting agent, one that would start working very quickly after the patient takes the medication, one that's very selective for the bladder, which I'll explain to you in a moment, and one that clearly has a low side effect profile, so it's well tolerated by the patient. The limitations of drug use, pharmacotherapy, are clearly the opposite of those things. In those medications where the side effect profile is high, the patients are clearly not going to stay on the medication for very long. Duration of treatment, especially when you've got a young patient, you don't want to have to tell the patient that they're going to have to be on a medication indefinitely. The cost of medications is, in some cases, prohibitively high these days, so that's certainly an issue to consider. One other thing is the precipitation of retention. What that means is pushing the patient into a point where they're not able to urinate at all. That happens very, very rarely, but it's something to be aware of, particularly, for instance, in men with big prostates and that sort of thing. What if the medications don't work? Are there any options other than medications? Well, absolutely. One is catheterization, and that is clearly the least favorite for all of urologists. We certainly wouldn't jump to catheterization. There are problems associated with a long-term indwelling catheter, so if we can avoid that, most urologists would. However, nerve stimulation, or making the bladder bigger, or actually diverting the urine completely away from the bladder itself, are all options, albeit a little bit more invasive than the other options we have just gone over. So let's look at neuromodulation. This is nerve stimulation. There are a couple of nerve stimulators that are available now. The most popular or most widely used is called InterStim, made by Medtronic. It's a two-stage procedure because what we do is we take the patient to the operating room for stage 1. We place a test stimulator in place, and then the patient goes home for a week wearing what looks like sort of a garage door opener or beeper-sized little external device, and the patient is able to turn the device on and off or up and down depending on the sensation. And during that week, if the patient notices that the urgency is affected positively or decreased enough that they think it's worthwhile to go on with the second stage, we actually go on 1 week later and implant a device that's about the size of a silver dollar underneath the skin and bury the whole device, the whole thing underneath the skin. And the patient's able to control it with an external device, but they don't have to wear anything. So about 90% of patients nowadays tend to go on to the second stage of InterStim. Now, the last resort, if InterStim doesn't work and all the conservative measures don't work, is to actually physically enlarge the bladder. It's a big operation, but it tends to work. At Virginia Mason, we can do it through a camera, so laparoscopically. So enlarging the bladder, now how do you do that? We take a segment of bowel, which in its native state is actually a tubular structure, and we open it up to make it flat. And then we open the bladder sort of like a clam in a bivalving sort of fashion and cap this piece of bowel on top of the bladder. This is just a little cartoon showing a picture of the surgery. This is a piece of the bowel being opened up so that it's a flat piece rather than a tube, and we sew it so that it's a big sheet of bowel. This is just a picture of the patient if their head is up here on the right side of the screen and their feet are down here on the left side of the screen, and this is the bladder This is the segment of bowel being sewn onto this bladder. So you can imagine you can double and triple the size of the bladder using this technique. So the take-home message, in short, is that incontinence is treatable. It is a very prevalent problem, and it clearly affects patients' quality of life. And I think the bottom line is that we all have a responsibility to educate each other on the idea that there are treatment options that are available. Ask your primary care provider about the successful treatment options that are available. Thank you.